Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome to episode 3 of 3 of the Treatment Progress in Triple-Negative Breast Cancer, Improving Disparities and Outcomes with New Approaches podcast series. I'm Dr. Bill Gradishar, and I'm joined by Drs. Yuan and Rita Nanda. Thank you to listening to our first podcast on the biology and burden of triple-negative breast cancer, and our second podcast on personalized management approaches in TNBC to enhance patient-centered care. In this third and final virtual roundtable conversation, we discuss new strategies and approaches to reduce breast cancer mortality and improve the disparities in health outcomes of racial, ethnic groups. TNBC has clinical features that include high invasiveness, high metastatic potential, proneness to relapse, and a poor overall prognosis. The heterogeneous tumor biology, aggressive clinical course, and higher metastatic potential underscores an unmet need for education and research to ultimately improve its prognosis. Moreover, we need more awareness on racially distinct differential gene expression signatures in TNBC and how these distinct features may provide insights into the mechanistic basis for aggressive TNBC and offer clues about druggable target space in racially diverse TNBC patients.
So that's a great segue again, going to the third part, addressing disparities. We all know that for triple-negative breast cancer, we talked a little bit about earlier regarding the race, ethnicity tends to happen, we tend to observe higher rates in Black women, comparing with Caucasians, and also higher rates in Hispanic patients. And because of the some of the issue we're going to address later, there has been observed higher incidence rate of stage 3 or perhaps stage 4, de novo stage 4 disease in this population. I think this is a nice summary of the potential issues, which factors contributing to disparities in triple-negative breast cancer. So on the top of the box, we saw like access to healthcare. Maybe I'll pause here, have Rita and Bill, you make a comments. What do you see in your practice that potentially will be a challenge? And actually, I looked into our cancer registry. We have 9% African American population. So definitely, I know their patients could not come to my institution for care. That is the biggest, obviously the top priority for us to tackle.
Yeah, there are so many things on this slide that are potentially, incredibly germane to your healthcare, but at the same time, there's just as many things with trying to live, so if you layer that on top of, a healthcare problem that develops, and just look at those two bottom boxes, you're just trying to get through your day to the next day and then layer some of these other things on top of it, including comorbidities. There's no surprise that this is an incredible challenge for many patients, and it's getting the justified attention finally, probably, that it always needed.
Yeah, I would agree with Bill. We actually have a large proportion of Black patients in our catchment area. 40% of my patients or of our patients are Black, self-report. And, when you think about the sort of factors that, who are these patients, at least in my practice, who have triple-negative breast cancer, a large portion are young Black women. And, there are challenges around who's going to take care of my kids when I come for treatment for my triple-negative breast cancer. And so I think there are a lot of things that we as the healthcare community need to do to help patients get the care that they need. A lot of that is equal access to some of these novel therapies that we just spoke about, but also making sure that they have the support. And it can be very challenging that we get our social workers involved, engaged, and do community outreach. And figure out what we can do to help patients get the care that they need.
No, absolutely. And actually last month or so, I'm losing 3 young patients. They were in the middle of their neoadjuvant treatment, yet due to the disease-related condition, they're losing their employment. So again, it's sort of a vicious cycle. We're yet to find out how to help them. And even with, I'm living in California with a California government insurance Medi-Cal, sometimes it's still not sufficient. So I think this is really a huge challenge, in addition to the other factors. So because of all of these reasons we just described, there has been data clearly demonstrating in patients who already enrolled into trial setting, for example, there appears to be this information comes out straightforward that we have a lower percentage of patients in Black, for example, in SWOG study, 9% only. There's this large analysis looking at pharmaceutical companies sponsored trials, only 2.9%. So this is a conclusion that most imprinted to our impression that our African American patients' clinical trial participation rate is really low. But interestingly, there is a new data recently came out that sort of broke that myth. So this is an interesting study published in 2020 by Unger et al. They look at 35 clinical trials aggregating almost 10,000 patients. And the interesting question they asked is that if we offer or provider discuss and offer the trial to the patients, and would they agree to participate? So the conclusion was very interesting. Over 50% of the participants would join the trial, and regardless of their race and ethnicity. So it's very much different from what we understood earlier. So I thought this is really eye-opening, and I wanted to know your impression on this study.
Yeah, the notion that any patient, there's a lot of emphasis these days for physicians to be trained or be cognizant of implicit bias. And probably one of the things that we've been told by this data and other data is the biggest reason some patients don't participate is they never were told. So we're if you're in a place where you have trials and a patient makes that statement, it of course implies that the provider, the caregiver, is making an assumption about the patient from any of a number of different metrics that they're not going to want to participate, or they can't, or they won't follow up. So I think, it's a little bit of a lot of it is on us.
I would agree with that. I mean, I have to say something that I'm very proud of is, we have 40% patients in our clinic are Black, and 40% of our patients who participate in our clinical trials are Black. So we are proportional. Actually, for some of our triple negative trials, it's even higher than that because we just happen to see more Black triple negative patients. And I think some of the pharmaceutical sponsored trials that have been done maybe are trials that aren't open in areas where there's a racially and ethnically diverse patient population. I think there's always been a lot of focus in what are the sites that can put patients on the fastest, as opposed to let's make sure that we capture a diverse patient population in our trials. So I think there's something to be said for that. And I think this is a really important study. I have to say that, for my patients, every patient you offer a trial to, you have to be invested, and you have to take the time to talk to them about the trial, explain what it is. One thing that I'll hear is, well, I don't want a placebo. Well, you need to explain that if the standard of care is to have therapy, there is no placebo. You're going to get some therapy, and you may get some therapy plus something. And, so taking that time to, not just say, oh, I have a trial. Oh, no, I'm not interested in a trial. I don't want a placebo. I don't want to be a guinea pig, but really talking to patients. And there are some cultural issues here at play. And it does sometimes take a little bit of longer time to talk to Black patients because there's this history in this country of experimentation without informed consent. And so I think we really do need to take that time and spend that time. And I think this was really exciting to see these data, and hopefully it will reinforce to our community that we need to make sure that we're engaging with all patients equally and offering everyone equal ability to participate in trials.
So well said, Rita. So I can palpate your enthusiasm, and then I also echo the same. Sometimes, I would say we often have been told we have some subconscious biases toward those patients we take care of, and absolutely agree. We spend the time, we discuss, why the trial is designed, and at least if there's no placebo, as you said. So this study also raised an important question: is now the so-called precision-driven clinical trial design. For example, if we're studying track alterations or specific mutations, BRCA mutation. So by design, our clinical trial is limited to the population we intend to study. So I actually read this paper, and there's one of the calling for broader inclusion or less exclusion criteria. I wanted to hear both of you as experts in the field. How do you tackle this question? I often found that I'm inflected of how do we address the scientific question, but try to make it broader.
No, I think what I would say is absolutely, there are patients who have more comorbidities, and sometimes the exclusion criteria for trials are too strict and exclude some of these patients. And so I think we need to be very cognizant of that. And we need to push our pharma partners to relax some of the eligibility criteria so more diverse patients can enroll. And so I do think that is a very important thing that we need to think about as a community. And when we're designing trials as an academic community, that we do it with the goal of being able to be inclusive, as opposed to setting the bar so high that, if somebody's got a hemoglobin A1C of 6.5, they're ineligible or something like that. We need to make sure that we're inclusive and including people who have comorbidities that we don't think are going to impact the safety of the therapy, or doing our earlier phase trials in patients who might be, on the border, and we think maybe there is some toxicity or not, but just being more inclusive in how we design our trials.
Yeah, I completely agree. And, there's always that tension where a pharma partner or somebody looking for a registration wants a pristine population of patients. They don't want any surprises. But the reality is the surprises occur when people get this drug in practice. And if you don't want to treat somebody that's in liver failure with a brand new drug, but at the same time, some of these permutations of labs and so forth, as an example, are really reflecting real world practice. And I would echo what has been said, that having inclusions like that are important. We've seen that, of course, with the approval of, certain HER2 drugs now, where somebody took the bold step of allowing patients with active brain mets to be part of trials. And, that was actually very enlightening, I think, for a lot of people.
I think it paid off.
Yeah.
So, absolutely. And I think the only other comment I wanted to make is, that I've had on occasion is, patients who have benign ethnic neutropenia being excluded because their ANCs are a little low, but that's normal for them. So I think there are certain criteria that need to be thought about and adjusted.
No, absolutely. Well said. And I would keep on going and wouldn't be able to stop, like the RECIST criteria for bone-only metastasis. It's really challenging. All right. So thank you for, all these opportunity for us to discuss triple negative breast cancer in the short amount of time. We covered a lot of issues, and we went from biology to therapy to the future, and to criticize on the current limit on the clinical trial design. So I think in conclusion, triple negative breast cancer is not one disease. It's molecularly complex and heterogeneous. Despite its aggressive cancer with disparity in the stage of diagnosis and survival among different ethnicity and races, we're making progresses. And now we have a lot more therapeutic options for these patients, going from conventional chemotherapy to immunotherapy to antibody drug conjugates to target therapy, and unique, sometimes tumor agnostic treatment options for these patients. And lower cost and mortality seen when treatment is consistent with evidence-based guidelines. And also, we still calling for innovative program, innovative clinical trial design to address a very important disparity in triple-negative breast cancer care. Thank you.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.